Most people here know me. So if you want any more information, you could read the bio. And I just got this newspaper. I haven't seen it yet, so I'm going to be looking at it. But some of these get dropped by here every month?
Yes.
You said, Marcus?
Yes.
Okay, great. Well, and everybody got it. I don't know if you all got a copy, but there's a copy of the lecture I'm doing, so it makes it easy. And some of you have heard it before, but you probably didn't memorize it all, so you might benefit from hearing it again. Because we're going to talk about dissociative disorders. Yes, and especially dissociative identity disorder, which used to be called what? Multiple personality disorder, yes. Yes, I never did know exactly why they changed the name, but somehow they did. Maybe MPD got a bad name or something. And now, you know, it used to be you heard very little about it. When I was in graduate school in the 70s, it was considered like if you ever saw a case, it would be like a miracle. And then over the years, they've discovered that that's not true, that there's a lot more than they thought at one time. There are still people in this field that don't believe in it. It's interesting to me, we have this DSM, which of course is imperfect, but nonetheless gives us some information on diagnosis. And I haven't heard anybody argue about the other diagnoses. Nobody says, I don't believe in depression. Yeah, well, so anyway, a lot of times people who have dissociative identity disorder have a really hard time finding a therapist because there aren't lots of them out there, you know, who this is a specialty. Since you guys know that I got my specialties accidentally, that I started working with women in the helping professions because I was a professor of nursing, and then so I got a lot of people who were women in the helping professions. If you get a lot of women in the helping professions, you get a lot of survivors of childhood trauma. You get a lot of survivors of childhood trauma, you get a lot of addiction. You get a lot of addiction, you wind up with a bunch of bipolar disorder patients. So that's how I got my 3 specialties. But if you specialize in PTSD and really, and I started working in trauma, as I've told some of you guys, before there were any books or any workshops, and we all just kind of learned by the seat of our pants and by our mistakes, and you know, and found out what worked. And if you do specialize in PTSD, you're certainly going to get a certain number of patients with dissociative disorders. If you get a certain number of patients with dissociative disorders, you're going to get eventually some with DID. And it's a diagnosis that doesn't get made quickly. People are frequently misdiagnosed. Sometimes it takes up to 6 years for people to get a diagnosis. Sometimes it even takes quite a while, even if they go to someone who specializes in it. I rarely, right off the bat, diagnose someone as DID. Most of the time, I start out diagnosing them as DDNOS, dissociative disorders not otherwise specified, because it takes time to really kind of tease everything out and kind of figure it out and see whether it's stable or whatever, and then you can go from the diagnosis of DDNOS to the diagnosis of DID. And most of the people who have this disorder have been either physically brutalized, psychologically assaulted, sexually assaulted, and affectively overwhelmed. Okay? It's important to remember that chronic exposure to sexual displays or sexual acts during infancy and early childhood is child abuse. Okay? As well as the other part of this child abuse is punishing children for sexually acting out when they're little, when it's not, you know, like, when do kids first masturbate? When they're really little. you know, it's not a sexual act so much as it's a comforting act. But a lot of times they really get corrected for it, and a lot of times they really get punished for it. And that's child abuse also. What should you do with a little kid that's, you know, has a tendency to masturbate just anywhere, out in the living room or walking down the street or whatever?
You gently set a boundary about that being a private activity?
Yes, yes. Just like they learn not to go potty in the middle of the street or the middle of the sidewalk or the middle of the living room, and they learn not to masturbate. And it is just makes it a normal thing, but that it's a private thing. That's right. Okay. And sometimes we forget that physiological abuse also includes over-medicating a child or unnecessarily medicating a child. And there are a lot of people who do that. And they don't consider it child abuse, but it is. Okay. Actually, DID is a mode of survival. You know, when abuse is so severe, so chronic, and so overwhelming, a little kid can't get away, right? They don't have the power to leave, so they've got to get away somehow. So they get away in their heads. And some just get away in their heads. And some float up in the ceiling someplace and watch what's going on. Those are dissociative episodes. But some, if it goes on long enough, they split. And, you know, when they split, sometimes there's just one part of them that knows the abuse, that remembers the abuse. Because sometimes there's one part that takes the abuse, and the other parts are not so aware. And people that split like this most of them are bright, creative. If you think about it, you have to be pretty creative to split off into these different parts and have them have such lives of their own. But each part comes into being for a purpose. And different parts may deal with different issues. One part may have taken the abuse, as I said. Another part may do sexual acting out, or just be the sexual person. Another part could be psychotic. Another part could have diabetes. And they could have different brain waves. And we really don't know the answer to this, but there's physiological evidence of it. So it has been demonstrated frequently. So they're bright, creative, and you know, just in general, survivors of trauma, of childhood trauma, are some of the best actors I've ever seen. Some of them could win an Academy, they could do Academy Award performance. Others are unable to cover up, but some do a really good job of it. And they may have feelings of derealization lots of times. They have headaches. They can have hysterical conversion on top of the DID. And depression's common. The onset's in early childhood, although it's usually not recognized until adolescence, later adolescence usually, or adulthood. And we talked about one time about why do you think it might not be recognized in childhood?
Children have big imaginations anyway.
They have big imaginations anyway, and most of them have what?
Imaginary friends.
Imaginary friends. And that's normal, right? Just like there's normal dissociation. Dissociation's on a scale from normal all the way up to DID. And we all experience normal dissociation, I know I've said to you guys, the interns before, many times that you get in a car, you pull away from the curb or pull out the driveway, and you, all of a sudden you're driving up to someplace. It's the place you were going to, and you don't have a clue what happened in between. And you hope to God you didn't run over anybody or, you know, do anything inappropriate. But it's not that you're not paying attention, it's just that it's not there. So they become real experts at that. And the thing is that they can't control it. When people learn to dissociate as a defense mechanism in childhood, it just happens automatically in adulthood. Whether it's the kind of dissociation when someone goes back in their head, or the kind where they're floating up on the ceiling, or the kind where they're split off, they can't control it. They have to learn to, but I mean, they don't automatically control it. And it's really one of the things to look at particularly, and one of the questions to always ask if you suspect that someone is dissociating, is to ask them if they're losing time. Now, again, we all lose time occasionally, right? It's like, I can't believe it's 2 o'clock. But we do know, if we think about it, we know what we did up until 2 o'clock. Whereas when they lose time, and all of a sudden it's this time, they don't know what happened during this period of time. People wind up on freeways they've never been in before, they wind up places they've never been before, they wind up doing things and having no clue that they did them, all kinds of stuff. So you can imagine how out of control their lives feel. They really have a tough time with any kind of relationship, you can imagine. And why do people know more about DID now than they used to? Because of movies and TV shows. What was the TV show that had? Yeah, United States of Tara. Yeah, and there is an increased prevalence in women. There are more women, but they used to think it was definitely just women, but that's not true. And there's a good book on men called, let's see, The 5 Lives of Billy Milligan, I think it is. And then the best novel in general on DID is first person plural. Because if you ever work with patients who have DID, they don't say I, they say we.
There was a good movie.
Huh?
There was a good movie called Primary Fear with Ed Norton, I think, about the DID.
Good. Yeah, there's more stuff out there now. Clinically, we're still not seeing, it's hard to find somebody who specializes in it. It is increasing. I know I mentioned that I'm a member of a group that meets at CSPP once a month. We're all people who work with DID, or people come who want to learn more about working with DID, because we have different speakers. You know, like I spoke a couple of months ago, and various other people have spoken. And over the year, it's been going for a couple of years now. It's a really good group. It's free, and anybody's welcome that wants to go. It's on a Thursday evening. Because one of the professors at Randy, what's his name? Noblitz, yeah, is a specialist in cult abuse and DID with cult abuse. Because not only have a lot of DID patients have physical, sexual, and emotional abuse, but they also have cult abuse. And some of the stuff is just like unbelievable, some of the stuff they've gone through. It's unbelievable that they survived it all. Actually, there are, in history, they've traced DID back to the 1600s. They have some identified cases described back in the 1600s. Oh, by the way, when I mentioned the different things they can do, that one part can have diabetes and stuff, they can be different-handed too. One part can be right-handed and one part can be left-handed. It can be very confusing, and the handwriting is different. And this will often give you a clue. If your patient journals, and I encourage all patients, but especially addicts and survivors of trauma, to journal. And when you start looking at a journal, when they bring it in, and see different handwritings, you might be suspicious. Because most of us write the same. Sometimes our handwriting is a little worse than others, but it's still the same kind of handwriting, whereas theirs can be like totally different. Because the various parts that they have, there are always child parts. And some child parts are so young they can't write, so if you want to communicate with them, it a lot of times has to be with drawings. You can talk to them, but they can draw. They can't write. I said it was often misdiagnosed. What's the most common misdiagnosis?
Schizophrenia.
Used to be schizophrenia. Borderline. Borderline now. It was schizophrenia for many years. Now it's borderline. And every patient that I know that has DID, that needs to be admitted to the hospital, when someone's doing a biopsychosocial on them and says, "Do you hear voices?" What do they say?
No.
They say no. And they're lying. Okay. But they say no because they know that someone's going to automatically think they're psychotic. And the voices they hear is in their head, and it's other parts of them talking. Or sometimes they just hear noise at first before they can differentiate. And I have one patient right now who has DID who mainly dissociates during the night. She finds evidence in the morning that she's dissociated during the night. So she has, she's been working on it for a long time, so she has more control when she's more awake and alert and so forth. But at night, she wakes up and she finds all kinds of evidence that she's dissociated. Sometimes she's fallen down, then that, she does remember that, but, because she has some physical problems also. So since they're misdiagnosed, since they're not diagnosed properly, then of course they don't get treated properly. And they try to take care of themselves to some degree. By the way, I tell all my trauma survivors, as well as not just the DID patients, that the more different media that you use to get feelings out, the more effective it is. You talk about it in therapy. You write about it in a journal. And it's important to do art. It can be any kind of art, and the person doesn't need to be an artist. And if people absolutely won't do art, then what I've found effective is encouraging people to do collages. It's just amazing, some of the collages I've had that people have done. And they're so expressive of their feelings. And, they can just take them out of any magazine. They don't have to be artistic to do that. So, and sometimes what I do is have them do a couple of collages. One collage of what they're feeling now, and one collage of where they want to be. And you see a lot of difference in those two collages. And hopefully they don't just do it once, and they do things periodically, and you can see the changes also. So like I said, there are always some child parts. There are parts that have different jobs. One may express anger or depression. Like I said, may act out or just be involved sexually. There's almost always a protector. Someone's a protector. And that's, when we get to treatment, that's, the protector is one that you want to be, well acquainted with. Okay, they can be various ages. They can be the opposite sex. And it's interesting, if one part is out and you don't recognize it, and you address what you think you're addressing the host, that one could get insulted. So, you have to develop relationships. Okay, and what Clough said, again, he's one of the big writers on DID, he's been treating it for many years. And Clough, Colin Ross, Putnam, Frank Putnam, those are all writers that have done a lot of work for many years, both research and clinical work in DID. And he says that treatment will sink or swim on the quality of the therapeutic alliances developed with the parts. So that's what's really tricky, because you're not just developing a therapeutic alliance with one patient, which is what we usually do, unless we're doing group therapy. So all of a sudden, we're doing group therapy with one person. And it can be, and at first it's very tricky because you don't recognize that necessarily. And at first, people don't have what's called co-consciousness. It means a part can be out and doing things and saying things, and the host doesn't know. Sometimes another part may know, may hear it and may know, but the host doesn't know. And we really have to establish a mutuality of working together and recognizing the difficult nature of the job, because it is difficult. It's not, and this job has to take priority over everything except safety issues, because otherwise it's not going to get done. And of course, safety, prevention of harm to self or others is the most important thing. But after that, you've really got to focus on this difficult work. And so the goals then, of course, is to develop co-consciousness, to keep working with the different parts and encouraging them to let each other know what's going on. And remember that when a different part comes along, or if you think somebody's part is along, you ask. And then you introduce yourself. So you may, it seems strange when you first do this. Later, there's nothing to it. But at first, it seems weird to be introducing yourself to what it seems like the same person a half a dozen times. But you're really introducing yourself to a half a dozen different parts that don't know anything about each other. And they all need to trust us. Otherwise, we're not going to. And do you think they do?
No.
No, absolutely not. No, there's no trust to start out with, because how would anybody who's had that kind of background have any trust? Just because I say I'm a doctor and I'm here to help you. They think to themselves, yeah, I've heard that before. So it takes time to build up these relationships. And so besides co-consciousness, we want to develop executive control. Yes?
When you say host, do you mean the original person before the
Yeah.
other parts were?
Yeah.
Okay.
Yeah, sorry, yes. The host is the person, herself or himself, without parts.
Okay. Now, is there a level of relationship that the original one, let's say, that one should be older, maybe 12 years old before the other parts were added to it. So is there a level of respect or relationship that exists between them that one says, okay, I'm in charge now, you all keep quiet? And
No, that's the goal. That's, besides co-consciousness, one of the goals is called executive control. And that means I'm the host, I'm in charge. But I can't do it like a dictatorship. It needs to be a democracy to some degree. You need to get buy-in, you know how we need to get buy-in from patients in order to make any progress in therapy? Well, not only do I as a therapist need to get buy-in from all these parts, but so does the host. Because typically, they don't trust the host. Because the host is the one that got them into this mess to begin with. Got them abused. So, and sometimes they think the host is a wimp, because they don't stand up for themselves. And they have all kinds of different feelings. And, you know, these are all things that need to be talked about. And so, besides working towards co-consciousness and executive control, one of the ways we do that is I recommend that they have regular family meetings. Only it's an internal, not an external family. But basically, you use family systems approach, just the same as you do for an external family. So you can use lots of different systems of psychotherapy with one patient.
Could you use the, like, Jungian, you know, animus, all the different parts?
You can use whatever you want. You can use whatever you want. But the family meetings and the consistency of the family meetings is really important. And most of the time, you really need to have a family meeting first with them, you know, helping them call the family together. Because they're really scared to do that. And if you think you feel weird, they feel more weird. So, it's important to let them know. I always prepare them for family, especially in the beginning, that, you know, just like an outside family, you can call a family meeting, and sometimes somebody's working, somebody's going out, somebody forgot, somebody's pissed off. Sometimes maybe nobody comes. So the important thing is the consistency. Not only do they all need to build up trust in you or me as a therapist, they have to build up some trust in each other, they have to build up some trust in the host, that the host is really going to have a family meeting and going to listen to them. And they need to say things like, we want to have a family meeting, and I'd like you all to come, and I'd like to hear what you have to say, I'd like some input from you guys. You know, and I'd like to also be able to talk to you. So preparing them like that and letting them know that the important thing is the consistency. If they keep being consistent, then some trust will build up and parts will start coming to the meeting. And sometimes they might come and not participate. But again, consistency, building up trust, eventually they will come and they will participate. And then they can actually work together to try to increase co-consciousness, increase executive control, decrease, because one of the things they need tremendously is affect regulation. They're really affectively, frequently out of control. Sometimes abreaction is used. Do any of you know what abreaction is? It's similar to a flashback, only it's one that you deliberately trigger, either with hypnosis or suggestion, where they go through a situation where they went through, that all these feelings came up, but now they come out. So it can be very, sometimes patients go into abreactions spontaneously. You don't know you've triggered anything. And it can be very scary because they're like right there when all this stuff was happening, just like with a flashback. And it's not so much recommended in outpatient treatment because it takes the patient a long time to get kind of sort of back together again. They can get out of the abreaction, but to kind of feel safe and feel together, it takes a while. So it's much better if they're in a safe place, like if they're here, or if they're in a hospital or someplace where there's somebody to keep an eye on them. Because there are a lot of suicidal feelings among DID patients, and a lot of self-injury. But these patients also remember that we tend to have a goal of integration. Get all these parts together so there's just all back together again, there's just one. The parts look at integration as killing them. We're killing them off. So that's something that has to be dealt with, and it needs to be talked about, and they need to eventually understand that they're all still gonna be there, they're just not gonna be split off anymore. Because we all have different personalities at times, right? Only they're right here with us, they're not split off someplace. I mean, we all, some days we're grumpy, and some days we're happy, and some days we're depressed, you know, so we can have lots of different parts of us, but the parts are integrated, they're not split. So they need to learn about how that happens, and most of the time, maybe just 2 or 3 people, parts rather, not people, integrate before they merge, because they're more similar. So the ones that are more similar can kind of get together and merge. And then you gradually reduce the number so that then eventually everybody can integrate. If they want to. If they don't choose to integrate, they're not going to. But, yeah.
Is it possible that they can integrate, and then if there's a lot of trauma again, stress, they can just go back to being the individual parts again?
Yes, if it happens early on. Because, yes,
I do want to interrupt.
That's fine.
Also, when they are merging, sometimes I recall that sometimes some would choose to leave and they say goodbye, and it's a process of them saying, I'm not needed here anymore, and they would.
yes, they can do that.
Mhm.
They can choose to leave. And everybody can grieve, or, you know, and talk to them and say goodbye and stuff like that. And that's one way of doing it. And that happens. And then, again, that's usually a spontaneous thing. And the other is merging, and the other is then integrating. And I know I mentioned to some of the interns, I had one patient that didn't want to integrate. She told her psychiatrist and me that she felt sorry for us because we didn't have anybody else to do our housework. She had another part that did the housework.
Oh, wow.
But then I also told you about the experience that I had this same patient in group, because I used to have a DID group, and you know, I think that's fascinating and tricky and keeps you on your toes. I hadn't thought about it till I saw her crawling around the floor playing. I had to announce that children couldn't be in the group. It was an adult-only group. And that if there were any children there, I would be glad to talk to them afterwards. I certainly, you know, wasn't rejecting them, but this was an adult. And also, this is one of the things that patients need to be taught, and that is that when they get into a car, they kind of let everybody know, now, I've got to go here, it's going to take this long, and I need nobody to come out unless they can drive. And before sexual activity, it's important to say, because most of them have been sexually abused, so it's important to let the kids know that you're going to be involved in adult activities, and it's not a place for them to be, and that you will talk to them later. It's always important to say that you'll talk to them later so they don't just feel like they're being dumped or something. So, anyway, that's how I learned to have that rule of saying adults only in the group. It was a great group, though. I'll tell you, like I said, it really keeps you on your toes, but they're so on their toes. Because they're all hypervigilant, of course. That if I missed anything, I didn't need to worry because somebody else in the group would pick it up.
Dr. Carlson?
Yes.
I would think people would get very triggered in the groups. What do you do to help them to stay in the group?
Triggered by other people's experiences.
Triggered in general? but-
Yeah. Okay, I always had a co-leader.
Mm.
I always had a co-facilitator. I never did the groups by myself, unless somebody was sick, it might happen once or something, but there needs to be, and I think this is true of trauma groups also, and all the trauma groups that I did were the same. That I let the patients know if they get triggered or if something is too upsetting to them, they can leave. And they need to get themselves together and come back. But then the co-facilitator goes out and helps them, process and calm down and regain control and come back in. And I would not want to, I would never have a DID group or even a trauma group that I did by myself, even with all the experience I've had. There needs to be somebody to go out, if a patient needs to go out and make sure they're safe. Because remember, guys, that I told you guys, and I used to always tell my nursing students, first we have to keep them alive in order to treat them. So,
So
that's,
ideally, we should have co-facilitators for trauma and DID.
pardon?
Ideally, there should be co-facilitators in trauma groups.
Yes, that's what I'm saying. I never did one without a co-facilitator. I did in the hospital because I didn't always have a co-facilitator, but outpatient, I never did one without. In the hospital, there are other people they can go to, so they're not.
I'm curious how you avoided that. Like, what if you're asked to do that before you had your license when you're in the position we are? Like, how do you refuse to do something?
Well, I didn't do this until I was an
Oh, okay.
outpatient, because in some place, there's always someone else that can meet with them. Here, there's someone that can meet with them. In the hospital, there's someone that can meet with them. Outpatient, there isn't anyone
No.
unless you have a co-facilitator. So, the good news is these patients can be treated successfully. It's a neurotic, not a psychotic disorder, so it actually can be cured. But unfortunately, or fortunately for your pocketbook, I guess, integration is not the end of therapy, because then they need post-integration therapy, because they need therapy as a single person. They've been having it with all these parts and stuff, so they need to, when they get to a single person, that's different for them. So they need some therapy regarding that also. And
Do they mourn the old parts?
yes. Yes, they do. Yes.
Have you had instances where there was an integration at the end and the host was eliminated? And the integration is maybe some other one that started 2 or 3 years, I don't know. Have you had the experience of having the host eliminated while the rest remained?
No.
It never happens, and it will never happen.
If the host were eliminated, the rest would not remain,
Okay.
because there's only one body. I also remind them that there's just one body. Yes.
Are they able to access the other part? So, for example, when you said that she was crawling around on the floor and it was the child coming out, are you able to tell her, Mary, can you bring back Ashley so that we can start group and then there can be a switch, or is there no access to the other personalities once?
No, there is. You don't necessarily have it all the time. Well, you think of all of us. We can be stubborn, we can be in a bad mood or something, so sometimes they just, won't do it. Most of the time, once you've really built up a trusting relationship, and you've built up some relationships with the parts, then you can do that. And one thing you always wanna make sure of, when someone leaves a session, the adult host needs to be there and in charge. Unless there's another part that does a better job of it, which sometimes happens. I know I mentioned that I had a patient that was a nurse, and she was working. And this was such an ethical dilemma for me, because I couldn't really report her. That would violate confidentiality. It turned out that another part of her was the very competent nurse. And luckily, it was a hospital that I used to be a professor of nursing, so it was one that I knew people there, so I could kind of check on her without checking on her. And she was doing just fine, so then I stopped worrying, but for a while I was really worried, and I was really in a dilemma about, what to do. But it worked out well. And I've had other patients with DID that there was one part of them that went to school. And I really highly recommend that all of you read First Person Plural. This guy was in graduate school. Psychology, PhD. You think you have it tough?
Can you repeat the name?
First Person Plural.
Did he have a part that studied for the EEE? That would be good.
The book ended before he took the EEE, but he did pass it because he's now a psychologist. And he did recover. So, and the question about can they sometimes break apart again? Early in integration, that can happen. Given a very stressful situation, that could trigger splitting off again. Because like I said, remember that's when you've been using any defense mechanism for a long time, you go into it automatically. And just like I tell you guys, habits are like a roadmap, like a road in your brain. And once they're built, they can't be deconstructed. But the good news is you can build new roads. But if you don't maintain the new roads and keep maintaining them, given stress, you will get back to the old roads. So this is the same thing, only after a period of time that doesn't happen. But early on, like say the first year or something like that, that could happen. Treatment of these patients is always very painful for both the patient and the therapist. And it's never short. It's never short. So like when we've had DID patients here, we can only what?
Stabilize.
Stabilize. Yeah, work on stabilization and containment. And we can work on family meetings and all these things, but it will be just a beginning. And then they need to move on and a lot of patients don't know unless we tell them that you really need to get a therapist that specializes in trauma, if you're a trauma survivor, that specializes in addiction, if you have an addiction, and that specializes in DID, if you have DID. Because the thing about DID is it's very fascinating, and it's fascinating for everybody, people in the field, people outside the field. It's okay for it to be fascinating outside the field, but if you're too fascinated while you're working with someone, that's not a good thing. You can see where that might cause some counter-transference difficulties, because you're more interested in your fascination than you are in your patient. So, one of the common questions people ask me when they find out that I work with DID is, what are the most personalities you've ever worked with? I've had that question so many times. My answer is always the same. I don't know. I don't count them. like, what's that book, is it Rapid Roars or something? Anyway, you're supposed to have 94 personalities. Well, I don't know how you count 94 personalities. It doesn't matter. What you need to work with is what's there. And you need, remember, you not only need family systems, but you need developmental approaches. Because the different parts that are different ages need to be approached developmentally. Any questions? All right. Thank you, guys.
Thank you.